With pancreatic cancer, the size of the tumor isn't always the most important question. Sometimes, what matters more is what the tumor is touching. A tumor may be relatively limited in size, but if it sits very close to a major blood vessel, removing it safely can become much more difficult. So when doctors evaluate pancreatic cancer, they're not looking at just one thing. They're putting together a much bigger picture, where the tumor is, whether it has spread, how it relates to nearby blood vessels, how well the person can tolerate treatment, and what biological features the cancer carries. And that starts with understanding what pancreatic cancer actually is. So, what happens when someone develops pancreatic cancer? The pancreas is a gland deep inside your abdomen, behind the stomach and below the liver. It has a wider part called the head and a narrower part that extends toward the tail. And this small organ has two very different jobs. One is digestion. The pancreas produces digestive enzymes, substances that help break down the food you eat. The other is hormone production. It makes hormones such as insulin, which helps control your blood sugar. Pancreatic cancer happens when abnormal cells in the pancreas begin growing out of control and form a mass or tumor. But here's something important. Not every pancreatic tumor is the same. The main types include pancreatic adenocarcinoma and pancreatic neuroendocrine tumors. Adenocarcinoma is by far the more common type, and it's the type we're focusing on here. It develops from the exocrine part of the pancreas, the enzyme-related side, most commonly the duct lining cells. Neuroendocrine tumors are much less common. They develop from hormone-producing cells and are managed under different guidelines. So when someone says pancreatic cancer, the first question isn't only, where is the tumor? It's also, what type of tumor are we dealing with? Once doctors suspect the common type, pancreatic adenocarcinoma, the next challenge is finding it accurately and determining how far it has gone. Why isn't pancreatic cancer simply found with one routine scan? The pancreas sits deep inside the abdomen, behind the stomach. That location can make the cancer difficult to evaluate, particularly when the disease is being investigated early. So doctors don't simply order an abdominal scan. They use a specific imaging approach called a pancreatic protocol CT or MRI. The idea is simple. Use imaging in a way that gives the medical team a detailed view of the pancreas and the structures around it, especially the major blood vessels. With CT, contrast can help make the tumor and nearby blood vessels easier to see when it is safe for the patient. And those blood vessels matter a lot because the relationship between the tumor and those vessels can later affect whether the cancer can be removed surgically. But doctors also need to know whether the cancer has spread beyond the pancreas. That's why standard staging imaging typically includes CT scans of the chest, abdomen, and pelvis, done with a dedicated multi-phase protocol when possible. If CT doesn't clearly answer whether the liver is involved, an MRI of the liver can provide extra detail, and studies show it can detect small liver metastases not seen on CT in about 10%, 23% of cases. Then there are blood tests. Doctors may check liver function tests, particularly when there is concern about blockage of the bile ducts. They may also measure a tumor marker called CA19-9. And this is a test that is very easy to misunderstand. A high CA19-9 level does not by itself prove that someone has pancreatic cancer. CA19-9 is not useful as a primary diagnostic test. Some people with pancreatic cancer can have normal levels, and some people don't produce CA19-9 at all, about 7%, 10% of the population. And other non-cancerous conditions, such as a blocked bile duct, can raise the level. So don't think of CA19-9 as a simple yes or no cancer detector. Think of it as one piece of a bigger puzzle, often helpful for tracking disease burden and response over time. The diagnosis itself often requires tissue. That means a biopsy, taking a small sample of tissue and examining it under the microscope. A preferred approach for tissue confirmation in many cases is a needle biopsy guided by endoscopic ultrasound. In simple terms, doctors use ultrasound from inside the digestive tract to locate the area they need, then guide a needle to obtain the tissue sample. One important nuance: in clearly resectable cases, where surgery is planned right away, some guidelines note that biopsy may not be routinely required before surgery. But biopsy is generally recommended before starting chemotherapy. An EUS-guided biopsy is preferred over CT-guided biopsy for localized disease. And there's another important point. Circulating tumor DNA from a blood test, sometimes called a liquid biopsy, is not recommended as the standard way to confirm pancreatic cancer. So now we know how doctors confirm that the cancer is actually there. But there's another question that changes almost everything. How far has it gone? Once pancreatic cancer has been confirmed, doctors need to describe its extent. That's what staging is about. The stages run from 0 to 4. To keep this accurate and easy, stages describe whether the cancer is limited to the pancreas, involves nearby structures or lymph nodes, or has spread to distant organs. Stage 4 means the cancer has spread to distant organs, commonly the liver and sometimes the lining of the abdomen, called the peritoneum. But here's the part that many people miss. Stage is not the whole story when doctors are deciding whether surgery is possible. They also need to look at the tumor's relationship with the major blood vessels around the pancreas. For cancer that has not spread to distant organs, doctors can describe the tumor as resectable, borderline resectable, or locally advanced, based largely on tumor-to-vessel contact. Resectable means the tumor can likely be removed surgically. Borderline resectable means the tumor is close enough to important blood vessels that removing it cleanly is difficult right now, so treatment is often given first, followed by another assessment. Locally advanced means the cancer involves critical nearby blood vessels to an extent that surgery is not initially considered safe. But even here, the story doesn't necessarily end. If the tumor responds to initial treatment, some patients may later become candidates for surgery. There's one more key piece in decision-making: the patient's condition. Doctors may use something called performance status, which is simply a way of describing how well a person can function in everyday life. The scale runs from 0 to 4. Lower scores mean better functional status. This matters because the body has to be able to tolerate the treatment being considered. So the treatment plan isn't based on the tumor alone. It's based on the cancer, its location, its extent, and the person who has it. And that's why pancreatic cancer isn't managed by just one specialist. So who actually makes these decisions? Pancreatic cancer is complex enough that several specialists may be involved. Radiologists help interpret the imaging. Pathologists examine the tissue from the biopsy. Medical oncologists deal with drug treatments. Radiation oncologists deal with radiation treatment. Surgeons assess whether an operation is possible. There can also be specialists in genetics, care of older adults, nutrition, and symptom management. Each one sees a different part of the same puzzle. But there's another person whose role matters just as much: the patient. Treatment decisions also take into account the person's goals, physical condition, and personal choices. And guidelines recommend seeking care at a high-volume medical center experienced in treating pancreatic cancer, especially when surgery is being considered. So once the team has the complete picture, the next question is the one everyone wants answered: what can actually be done? There are 3 major treatment approaches commonly used: surgery, systemic drug therapy, and radiation. The combination depends on the individual situation. Let's start with surgery. For pancreatic adenocarcinoma, surgery is currently the only treatment with the potential to cure the disease. But surgery isn't appropriate for everyone. If the tumor is in the head of the pancreas, the standard operation is called the Whipple procedure. It's a major operation that removes the head of the pancreas, the gallbladder, part of the bile duct, the duodenum, and nearby lymph nodes, followed by reconstruction of the digestive system. If the tumor is in the body or tail of the pancreas, surgeons may perform a distal pancreatectomy, removing that part of the pancreas along with the spleen. And in rare situations, a total pancreatectomy may be required, removing the entire pancreas along with the spleen, gallbladder, and parts of the stomach and small intestine. But surgery is only one tool. The second major category is systemic therapy. Systemic means the treatment travels through the bloodstream and can reach cancer cells throughout the body. This includes chemotherapy. The source describes chemotherapy combinations such as FOLFIRINOX and gemcitabine-based regimens. There are also targeted treatments designed to act on particular molecular features of cancer cells. For example, PARP inhibitors such as olaparib may be used in the specific setting of an inherited BRCA mutation, especially in metastatic disease after the cancer has responded to platinum-based chemotherapy as a maintenance approach. And then there's immunotherapy. Certain immune checkpoint inhibitors can be used when testing shows specific features in the tumor that make these treatments appropriate, most importantly, MSI-high or dMMR tumors, which are uncommon in pancreatic cancer. The third major approach is radiation therapy. Radiation uses high-energy X-rays to target cancer cells in a particular area. It can be given together with chemotherapy, a combination called chemoradiation. Another approach is called stereotactic body radiation therapy, or SBRT. It delivers highly focused radiation and can be completed in 5 or fewer treatment sessions in selected situations. But it's not right for everyone, especially if the tumor is close to sensitive parts of the stomach or intestines. And there's one more option that shouldn't be forgotten: clinical trials. Guidelines strongly encourage clinical trial participation whenever possible because it's how better treatments are discovered and improved. But now we reach one of the most interesting parts of modern cancer treatment. Two cancers can be in the same organ and even have the same stage, but their biology can still be different. And that difference can matter when choosing treatment. So how do doctors find out what makes one cancer biologically different from another? Two important kinds of testing can guide treatment. The first is called germline genetic testing. Germline means the genes you were born with. This testing can look for inherited changes in genes such as BRCA1, BRCA2, or PLB2. The second is tumor biomarker testing. This looks directly at the tumor tissue to identify molecular changes found in the cancer. Here's the simplest way to remember the difference. Germline testing tells doctors about inherited genetic changes in you. Tumor biomarker testing tells them about molecular features in the cancer. Why does that matter? Because some molecular findings can point towards specific treatments. For example, BRCA1 or BRCA2 mutations can be relevant when considering platinum-based chemotherapy or PARP inhibitors such as olaparib in the right setting. If the tumor has an NTRK gene fusion, targeted treatments like larotrectinib or entrectinib may be options. If it has a BRAF V600E mutation, the source identifies dabrafenib combined with trametinib. And if the tumor has MSI-high or deficient mismatch repair, immunotherapy like pembrolizumab may be considered, usually in later lines of treatment. The important point is not that everyone with pancreatic cancer receives these drugs. They don't. The point is that testing can reveal features that may open particular treatment options for the right patient. So treatment isn't simply, here's the pancreatic cancer drug. It's more individualized than that. Doctors combine the diagnosis, imaging, stage, resectability, overall condition, and molecular information to decide which options make sense. But there's another side of pancreatic cancer treatment that has nothing to do with choosing a chemotherapy drug. It's about helping the person deal with what the disease is doing to the body. What happens when pancreatic cancer causes problems beyond the tumor itself? This is where supportive care comes in. Supportive care, sometimes called palliative care, focuses on relieving symptoms, managing complications, and protecting quality of life. And importantly, it is not only about the final stage of life. It can be part of cancer care while other treatments are happening. For example, a pancreatic tumor can block the common bile duct. When bile cannot flow normally, jaundice can develop, yellowing of the skin and the whites of the eyes. A common approach is placing a stent during a procedure called ERCP to help keep the bile duct open. A tumor can also interfere with the passage of food from the stomach. In that situation, doctors may use a stent or other procedures to bypass the blockage, depending on the case and local expertise. Then remember one of the pancreas's normal jobs, digestion. If pancreatic function is impaired, there may not be enough digestive enzymes available to properly digest food. This is called exocrine pancreatic insufficiency. The treatment is pancreatic enzyme replacement therapy, enzyme capsules taken with meals to help with digestion. Pain is another major issue. The source describes regular, planned pain control rather than waiting until pain becomes severe and involving pain specialists when needed. There is also a procedure called a celiac plexus nerve block. The celiac plexus is a network of nerves that carries pain signals from upper abdominal organs. Blocking these nerves can help reduce those pain signals in some patients. Other complications can also need treatment. For example, blood clots may be treated with anticoagulant medication chosen for the person's situation. In some settings, low molecular weight heparin is used, but the exact choice is individualized. And when appetite becomes a problem, the source describes low-dose olanzapine as one possible option in selected patients. So supportive care isn't an extra chapter added after cancer treatment. It's part of caring for the person while the cancer is being treated. In addition to these complications, signs like dark urine or pale stools, ongoing upper abdominal or back pain, and new or suddenly worsening diabetes, along with the symptoms already mentioned, can also be possible symptoms of pancreatic cancer, especially if they persist or worsen. If any of these appear, it's worth seeking medical evaluation promptly. So let's put the whole story together. Pancreatic cancer begins with abnormal cells growing uncontrollably in the pancreas. But once the diagnosis is suspected, doctors have to answer several different questions. What type of tumor is it? Where exactly is it? Has it spread? How does it relate to the major blood vessels? Can it be removed safely? How well can the person tolerate treatment? And what biological features does the tumor carry? Those answers help the multidisciplinary team decide between surgery, systemic treatment, radiation, clinical trials, and supportive care. And genetic and tumor biomarker testing can sometimes identify additional treatment options that would not be obvious from the scan alone. So if there's one idea to remember, it's this. Pancreatic cancer treatment isn't based on one number, one scan, or one blood test. It's about putting all the pieces together, and that is why two people with pancreatic cancer may not receive exactly the same treatment. If you or someone you care about is facing pancreatic cancer, use this information to understand the conversation and to ask your medical team better questions. Your actual diagnosis and treatment plan always need to be individualized by the healthcare professionals caring for you. You've been with MedVivid. If this video gave you a clearer understanding of pancreatic cancer, consider subscribing and turning on the bell. And if there's a medical or scientific topic you'd like us to explain next, leave it in the comments. MedVivid. We make medicine simple.